Our topic is on the Hospice Conversation. My name is Erica Herding.
And my name is Emily Kane.
This training presentation is for medical professionals who are educating their patients before they are referred to hospice. These are our learning objectives. Understand hospice misconceptions, understand what hospice is, identify the qualifications for hospice care, and understand the 8 steps to initiate the hospice conversation. It is important to educate people in hospice so that they can understand there are options after a terminal diagnosis and to provide a smooth transition into hospice care.
First, we're going to talk about some common hospice misconceptions. The first myth is hospice is only appropriate for the last few days of a terminal illness. The truth is, hospice's goals are symptom management and quality of life. If a patient's health status is in continual decline, he or she likely qualifies. The chart on this slide is showing the timeline from diagnosis of illness to the progression of coming onto hospice service. The next hospice misconception is a patient cannot leave hospice. The truth is, patients can come off or go on hospice as needed. Patients don't always decline continually after being placed on hospice services. Sometimes their health will improve and there will be need for them to be discharged. The map on this slide shows the percentages of discharges from hospices in each state. The national average of people leaving hospice is 11%. The next misconception is, if on hospice, a patient cannot receive any treatment. The truth is, hospice is not based on a no treatment philosophy, rather a shift in treatment goals. If a patient is on hospice for cardiac problems and then breaks a bone, that injury can be treated without coming off hospice. The picture on this slide shows the team that participates in the care to reach the treatment goals. They include volunteers, physicians, spiritual counselors, social workers, bereavement counselors, home health aides, therapists, and nurses. The final hospice misconception is that patients die sooner on hospice. The truth is, hospice care patients can live 29 days longer than non-hospice patients with a better quality of life.
Hospice is an approach to assist dying people, emphasizing pain management or palliative care and death with dignity. Hospice is focused on caring, not curing. Hospice can be done almost anywhere, including the patient's home, hospice centers, hospitals, nursing homes, and long-term care facilities. Hospice is available to anyone with a terminal illness, no matter their age, religion, race, or illness. It is important to check with your insurance company to see if they will cover hospice care costs. Medicare, Medicaid, and some private health insurance plans will cover hospice care costs. Now, let's look at this chart that shows nationwide hospice statistics. 1.43 million people in the U.S. had hospice care paid for by Medicare in 2016. Approximately 97% of hospice patients in the U.S. had their hospice care covered by Medicare, Medicaid, or private health insurance. 56% of hospice patients nationwide received care in their own home. There are certain qualifications required for hospice care. First, the patient must have a terminal illness of 6 months or less to live. The patient's attending physician or specialist makes a hospice referral order. Then the patient's referring physician and hospice physician must approve the patient for admission into hospice care. Lastly, the patient or caregiver signs consent forms for hospice care. This slide shows some health conditions most hospice patients have, including end-stage liver disease, end-stage kidney disease, lung disease, dementia, and end-stage heart disease. The most common health condition for hospice patients is cancer at 54%.
Now we're going to talk about 8 steps to initiate the hospice conversation. First, establish the medical facts. As with any important healthcare conversation, coordinate and communicate with other healthcare providers involved to ensure consistency in messages to patients and family. Second, you'll need to set the stage. Identify a time and place for an uninterrupted conversation and make sure that those family members who would share in decision-making can be present. Next, you'll assess the patient's understanding of their prognosis. You'll determine what the patient and family know about the disease status and prognosis. Then, you'll define patient's goals of care. You'll inquire about hopes and fears, help the patient and family reconcile their emotions, and to be clear about what they hope to achieve. After that, you'll identify needs of care. In doing this, you'll identify symptoms and other resources of distress that could be alleviated by hospice. Consider both physical and psychosocial needs and tailor the discussion to the individual patient and family. Next, you'll introduce hospice. Hospice can be introduced as a way to achieve the patient's and family's goals and to meet their needs. Use this discussion to dispel myths and to educate how hospice can help. Next, you'll respond to emotions and provide closure. Make sure you recognize and respond to the emotions of patient and family and fully explore any concerns raised before offering reassurance. Finally, the last step is recommending hospice and referring them to one. Depending on the patient and family, either arrange an enrollment visit or suggest an informational visit to allow them to ask more questions and become more comfortable with hospice. Now I'm going to elaborate a little more on a few of the 8 steps. The first one being assessing the patient's understanding of their prognosis. An example of how to assess the patient's understanding of their prognosis is to ask the patient if they understand their diagnosis and the available treatment options and testing that are still an option. The next step I'm going to talk about a little more is defining the patient's goals of care. An example of how to define the patient's goals of care are to ask the patients what are some of their goals they wish to achieve with their diagnosis in mind, and then address any concerns they may have after you discuss their diagnosis. The next step I'm going to talk a little more about is introducing hospice. An example of how to introduce hospice care is saying, after hearing the goals you said earlier, I think a great way to achieve those would be with the assistance of hospice care. Explain what hospice care is and what their main goals are. At the end, ask, do you have any questions or concerns you'd like to discuss about hospice care? The final step I'm going to talk a little more about is responding to emotions and providing closure. An example of how to respond to emotions and provide closure is by saying, I know this is a lot for you to take in. Is there anything more I can do to help make your transition to hospice care any easier?
These are our hospice resources for patients and for physicians. Patients can go to the National Hospice and Palliative Care Organization, and physicians can use the American Academy of Hospice and Palliative Medicine. These sites have research, statistics, education, and advocacy tools for information on hospice. Go to these websites or call these numbers for more information on hospice care. These are our references. That concludes our presentation. Are there any questions?